Never before in the history of humankind have we been so connected, from the way we use our smartphones, to social media, to emails, to everything else. The question is, has that permeated healthcare? Because we really do need that sort of connectivity to deliver the integrated care we aspire to, the patient's journey from home through the community to hospital and back again. 7 years ago, we did a similar project where we went to Royal Prince Alfred Hospital in Sydney, which in those days was one of the most IT-enabled hospitals in the country. What we found then was resistance to new technology. Well, does that still exist?
Calvary is a purpose-driven charity that's had a 130-year history in this country, where we're seeking to be a source of healing primarily, but also a source of hope and nurturing for these communities that we serve. We've always known and been cognizant of the need to integrate with the other providers. So it's about integration both within our Calvary facilities and our Calvary network, but more importantly now it's about integrating with the community's care network. What we see in our vision is a virtual service that gives people choice and improves the quality of care. The works that we and others undertake are generally pretty good, I have to say that, but unfortunately they're largely siloed. The challenges of the future are well appreciated, especially affordability, but having the right person at the centre of what we do is the other large challenge. That needs to change.
What we're really looking for, I guess, the holy grail of integrated healthcare across the primary and tertiary sector really would be seamless communication sharing, with an ideal IT platform. I mean, how marvellous would that be? And it certainly occurs in other places in the world, so I think we can head in that direction as well.
Sometimes our EMRs don't work, and that can break down the process, and then we have to redo the paperwork again to start the process all over again.
You've got to go in and out of screens all the time, which is quite frustrating.
Because we all have our own logins, those all disappear as soon as you log off. So now if you've got an interesting paper, all you can do is photocopy it and put it in the drawer. It's like going back to the 1960s.
The communication links between the pharmacy and the wards and even the prescribers, because it's not electronic, that generates deficits in the communication.
As well as sending the faxes, I've got to pull out all the medication charts to send through to the doctor. The hospital summary says, oh, they've been giving them this medication every 2 hours, and we don't have it here. And it can be a bit of a mad rush then to try and get more information from the hospital, to get our GP to chart that information.
I understand Mr Hamilton's going today with his daughter, is that correct?
Correct, yep.
Part of the hold-up is for some of the patients is once the patient's medically good to go and be discharged, we're relying on scripts being filled out, discharge summaries being completed to get the patient out the door, and often there's a delay from when they're actually medically fit for discharge and the discharge summaries and scripts have been completed for discharge.
We're a paper society at the moment here. It would be better if we had the technology to have it all on computer and have it a tablet with each doctor to bedside and so forth. It would capture everything there and then.
Ideally, I would have this on a mobile device. So I've got a time information, walking around the ward, I've got to come back to here all the time to find information or grab another PC in next door.
We've equipped our nurses now with tablets, so they can actually go out and do point of contact data entry. So that would be ideal if that was universal.
To share the electronic record, to share it widely so that every time a person touches the health system, it's possible for the provider at that particular location to have an instant view of where that patient's care is up to and the nature and complexity of all their issues, including medication, past history, etc. That would be absolutely magical.
So, as promised, here we are back again.
We really need to stop and reframe and reconsider what we're actually doing for us to meet the needs of people we care for.
So what we found was fragmentation, duplication, people doing excellent work, but it's despite the lack of technology or its duplication. So what we've done is we've gathered people together from these services, they're in this room now, and we're going to present the findings and see what they say. So let's just take discussion on what you saw there. The flavour I got from watching this and looking at it is that technology is not necessarily the answer to your problem, your issues in terms of integrated care.
Well, I think it probably is. I think it's part of the solution, but I think there's much
we have much bigger problems. So I think we need a way to identify objectively who's the cohort that we're looking after. Once we've identified that person, how do we universally assess them to make sure that the well-documented domains of care important to people facing the last 12 months are documented, and that documentation is shared. So regardless of if it's Fiona doing upgrading the documentation or if it's the general medical ward, how do we make sure that solution becomes universally available?
So it's documented in one place, one assessment for one situation that other people can share.
And regularly updated as needed. So community nurses have access to it, GPs, general medical wards, surgical wards, A&E.
Well, what would be the easy solution here, if only? Or is it not as simple
Having
as
the
that?
information at your fingertips and using one system.
So integration.
Integration's key because you've got, I've got multiple devices I use. I've got a deck phone, I've got a tablet, I've got an iPhone. You know, we're using multiple different systems to manage stuff. Our risk management, our patient interface, our journey boards. You know, we're ringing ED. We're talking to our executive. You know, there's no integration whatsoever. It's very fragmented.
The ideal world for us certainly would be an integrated health record that we can access. A good example was we had a woman come back from an acute care facility yesterday with absolutely no communication, absolutely none. She turns up on our doorstep, had suffered a major cardiac episode the week before, no communication. Because she's one of ours, she's family, she's been with us for quite a long time. We have these interrelationships where we should, where our duty of care is really quite, I suppose, emotional. For us to be able to press a button, so long as the server's up, and to be able to access whatever's gone on for her would just be ideal. We had no information whatsoever about what had transpired prior to her discharge from the hospital. Had pharmacy been notified? Had the doctor been notified? Had even her person responsible been notified? We had none of that information.
We've got a woman in the ICU right now. We've made 5 phone calls to a secretary to try and get her notes from the private system. When we found out something about her, we realised her cancer was everywhere. We'd been treating her aggressively, not realising that. This is 2 weeks into her stay, and we're still finding out new information about this woman that would influence enormously how she's currently being treated. And it's that slow. We're not just talking here about a delay of an hour or two. We're sometimes talking a delay of 5, 6, 7 days in finding out really important information. And the integration that we're talking about will have to include the private system because about 40% of surgery in this town is taking place in private hospitals.
My ageing parents live in the west of Scotland. They need a lot of social services and support to stay at home. They have a unified record. So a social worker could be on who's never seen my parents before and on her iPad are my parents' full records. The district nurses who visit have the same record. It's all on one iPad. They all share it. They know exactly, if I phone up the system, they know what's happened to my parents at 4 o'clock this afternoon. Why haven't we got that?
What they have is a culture that says this is the way we deliver services. That is, we don't have that really. What we have is a very fragmented, siloed system that's entrenched in policy, entrenched in our funding models at a national level. And so we can look at workarounds. We can create our own internal IT systems and devices. But essentially, we have to change the way we think.
So you can have all the relationships you like in the world, but if you actually want service improvement, you've actually got to have feedback on your performance.
Indeed, but if the relationships are not supportive enough that people are able to admit to making errors and then documenting them, then you're never going to get there.
So we've got local health networks. We've proudly said that Hunter New England is right at the forefront of health technology, and they've got different medical record numbers across the network.
And
that's outrageous.
Well, what they've done is they've been able to assimilate those 4 records, those 4 numbers on the Clinical Access Portal, not on us, but on the Clinical Access Portal, so that you can actually look up one person for an area MRN, for example, and still find all of their encounters and all of their results from the
And can
MARTA.
GPs do that?
No, it's only for Hunter New England Health.
So you aspire to integrated healthcare. New South Wales Health spending $130 million over 2 or 3 years on integrated healthcare and more to come, and you don't allow GPs into your system.
Well, my understanding is that as part of our Hunter Alliance, we're actually exploring and seeking ways that we can break down that firewall. There is a strong commitment to that, but technologically we're trying to explore ways to be able to do that.
We've got to change the paradigm like most other industries have and say, well, if we put the patient in the centre, what do we need to do? We almost need to throw everything out, and guess what? We've actually got a solution, and that's the cloud. So if you look at what the cloud offers you, it says, let's take the patient and let's put them here, and everything else has to manage around that individual. What we've got is the patient here and sort of everyone scurrying underneath through fax and phone and mobile communication to try and cater for that individual. Now, healthcare will say cloud equals risk, let's not do it. We've got to get over that stuff.
I think what's true in healthcare is that you never save money. But what you do is mitigate your rise in healthcare expenditure. And so that you're actually getting more for what you're spending and the priorities are changing. But that would be a better situation than throwing it against the wall.
What's been missing from the debate so far is the notion of accountability for what's going on here. I think one of the things that we also don't have is an overarching sense of who's really accountable for what's actually happening to this person. When you bring up the issue of advocacy, that's the level at which it needs to operate. Now, chronic care is moving in that direction where somebody manages your case. And I think without that element, we can integrate all we like, but we won't still provide care that's actually really tailored to that individual. We'll have just have integrated bad care, potentially, rather than good care.
So as a reality check, the insights weren't too far off the mark. The solutions, unsurprisingly, are complicated. I think that Fiona's challenge about relationships is, on the mark, that you can't get away from human relationships. It may well be that a lot of the solutions here are focused on a human being, which could be, my understanding is that, for example, if you've got a member of your family sitting at your bedside, you are in a much safer situation than if you don't. But it may be that there are some technological solutions that take you a little bit of the way and help out here. So, Rosemary, it's stuff you kind of knew, but now you really know it. And you know it tangibly. Joan and her team have observed this. It's documented. In a sense, it's data. What do you do with it now? It's hard to ignore.
Well, we certainly won't be ignoring it. That's one thing. I think we have to identify and appreciate the feedback that we have. The challenge, I think, for we here, and I'm sure it's the same across Calvary Silver Circle and aged care and our private hospitals also, is that we still have to be providing our services while we're trying to enact change. And so even though you've identified that there is a component of waste if we could not do this but instead do this, we still have to somehow do this while we're still trying to manage. So we've got to come up with a plan. Sue mentioned the time frame of 10 years, but presumably a time frame of what we can solve immediately, what we can solve in the middle, the longer term and the distant long term, and we have to engage with that and work with it. That would be my approach to solving this. Now that we've got the data, now we've got the evidence and the feedback, we know we've got as a given the very good will of our staff, we've got engagement with our senior executive and our organisation nationally. I think what we do is take the advice of experts and figure out how that fits with the capacity we have and make a plan for it.
Any other comments about the way forward?
The risk of not changing is so great that we must take the risk towards change.
It was really gutsy of Calvary Mater Newcastle to let us inside their workings, to see how they're operating in this modern environment. And if you're honest with yourself, the confronting messages you saw for Calvary Mater would be exactly the same for you. There's not a health service in Australia that doesn't have the same issues. And the solutions there sometimes are simple technological solutions, sometimes they're complex, but a lot of it's got to do with how people work together and change management. We hope this project has helped you in your world. Bye for now.